Welcome, everyone. We're so glad to have you tonight for our palliative care, helping the patient and family during serious illness. And we're thrilled to have Dr. Audrey O'Connor, Dr. Emily Hansen, and nurse practitioner Hailey Wank with us this evening. And with that, I will pass it on to our speakers. Thank you.
Well, welcome. Thanks for joining us tonight, and thank you to the Gilda Club for inviting us back. We actually gave this talk last fall and really enjoyed ourselves, so we're very honored to be coming back. So thank you. So my name is Audrey O'Connor. I'm one of the Palliative Care Fellows at KU. And the three of us are going to share with you information about palliative care, how it can help, when to use it, and so on and so forth. So the objectives that we laid out in a sort of a who, what, why, where, when fashion. So we'll go through what is palliative care, what the definition is, what does it mean, and what does it do? Who can receive palliative care? What types of patients is it for, and who gives it? Who is the treatment team? What does that consist of? What does it look like? And then when do I get palliative care? When do I ask about it? When is it appropriate? Gosh, I have do I need it? Does my family member need it? So this is not just for patients, but it's for families. We view patients as a complete unit with their loved ones and spokespersons. And then how can it help? What are you going to do for me? What's it good for? How's it going to benefit me? And then where can I get it? Where can I access palliative care? So we'll go through all that in different sections as we go. So I want to just touch real quick on the possible, it's very common that palliative care becomes synonymous with hospice. A lot of people make that connection. And I want to just introduce right now, palliative care does not equal hospice. Palliative care is not hospice. And I make the analogy of like dogs, like all poodles are dogs, but not all dogs are poodles. So all hospice falls within the bubble of palliative care, but not all palliative care is hospice. It's just a Medicare benefit. We can talk about at the end if you want, but I just want to kind of set that tone that really we're going to focus on palliative care tonight. Okay. So palliative care is defined as, we have the pronunciation there, and it's really a specialized type of medicine geared towards helping people that have a serious illness, a life-limiting, progressive, serious illness. And what palliative care can do is, we address symptoms, we address quality of life for people living with a serious illness, help with decisions and conversations. Sometimes there's difficult discussions with serious illness, and hopefully help alleviate some of the distressors that people and their families might encounter when they're living with a serious illness. And we often portray, say it's like an extra layer of support. A lot of people have many physicians, many treatment teams, and we can come in as this sort of extra layer of support that we can address special needs, multiple needs. It's appropriate for anyone, any age, at any time of their illness. So it's not based on the stage of that illness, the age of the patient, the prognosis of that illness. It's really just based on the need of that patient and their families for what they're experiencing. And it can be provided along with curative treatment. You can be having treatment, for instance, with cancer, you could be getting chemotherapy and radiation and be involved with palliative care and be seen by a palliative care physician. Next slide. So it's for people living with serious illness, and serious illness, serious life-limiting illness. So for instance, heart failure. Some people live with serious illness and heart failure for years, and maybe their serious illness is, shortens their life a little faster, and some it's decades. But all of these diseases, and it's not just these diseases, there's many, are progressive over time and come with symptoms, or maybe the treatment of this disease have symptoms. And so the palliative care is not limited to any type of disease. It's really just for people that have these illnesses that are having symptoms and needs that aren't being addressed by the other treatment teams. And who are those treatment teams? So the core team here at KU we're physicians, nurse practitioners, nurses, social worker, chaplains. Some places have pharmacists. Depending on where you might be in the United States, or even, in this area, it might just be a nurse, or it might just be a physician with a social worker, or it might be a big comprehensive team. It's variable. And then there's additional team members that, we can bring in to help, maybe psychiatry or speech therapy, bereavement services. So it's multidisciplinary team to help people living with a life-limiting serious illness, intended to be provided at any stage to address needs of that patient and their families. Next slide. And so this is a sort of a timeline of a disease. And when would I get palliative care? When would I want palliative care? Really, at any time during that stage of illness when you have those symptoms or you have needs. And those symptoms may not be just physical symptoms, pain, shortness of breath, nausea, vomiting. They may be distressing symptoms. There's a lot of psychological, social, spiritual distress that people encounter throughout the course of their illness that, those are more complex symptoms to manage, and palliative care, the team are equipped to help address that with patients and their families. So as you can see, it's the entire time. So maybe at the time of diagnosis, that can be a real shocker for some people, and very difficult discussions can be, might be needed. And maybe there's, you're considering treatments. A lot of treatments come with side effects, and, maybe you develop symptoms. And so all of these timelines in that illness, a pain crisis, maybe you're at home or in the hospital where you're treated, and now you have these residual symptoms that you're feeling. So really, again, it's based on the need of the patient and not the prognosis or the stage of the illness. Okay.
So I'm Dr. Emily Hansen. I'll take over from here. Thanks, Dr. O'Connor. So we're going to talk about the different aspects of how palliative care can help you out. And really, we're there, as Dr. O'Connor said, to help at any stage with any of the symptoms that really might come up. We do a lot of assistance with like pain control, anxiety, depression, constipation, nausea, lack of appetite, really any type of side effect that could come from any type of treatment that you're seeking, or any type of results of anything from the disease that you are trying to essentially live through. And because we understand that these symptoms really impact your ability to have a full quality of life living with the disease. And that's really where we shine in ways to help patients be more than their symptoms and live the quality of life that they want to and reach their goals. And that's where we kind of really assist with the care. So we do a lot of different medication management to help relieve suffering. We do opiates. We do also non-opiates. We're not just doing mainly opiates for people. We'll do them if they're indicated, but they're not always our standard. We'll look at other over-the-counter meds. We'll look at meds to help with mood. We'll look at meds to help with bowel movements and nausea and vomiting. We'll sleep aids. And then when we put all those together, we also try to look at all of the meds that you're already taking and try to mitigate any side effects that might be coming from the medicines that you're on, because we understand that when you have a serious illness, that those medication lists can get longer and longer and longer over time. And so really kind of mitigating the side effects of all these meds is really important. And so we often look at like, what other things can we take off? Because sometimes medicines can cause a reverse effect of what we're desiring. There's other ways that we look at relieving suffering, which is important to talk about, because oftentimes we have the opportunity to sit and talk with patients and take that longer time to really get to know them and understand kind of who they are and what's going on with them, and see, maybe they really connect with music therapy, maybe they really connect with meditation, or pets are important in their life, and how can we make them integral into their overall treatment plan. We'll refer people for physical therapy or help them with exercises or massage. I just actually recently this week used a technique that Dr. O'Connor presented on about massage with constipation. And so there's other things that we kind of take from our back pocket to really strive to reach quality of life for our patients. We also do sleep habit counseling. That's another one that comes up quite frequently, because we understand you get all these medicines, you're trying to coordinate all this stuff, and that can impact your sleep. So we try to do a lot of whole body care in the palliative care world. And this gets into also how we match treatment options with the goals. And, as I'm kind of saying throughout all this, is that we want to find out like what's important to you in living your life. Like, what are the things that you really need to do to reach those goals? Like, for some people who are really short of breath, if they're like, man, I just want to go out in my garden and work, but it's so humid out, how am I going to do that? We come up with treatment options to try to help them reach that goal. And so the other thing is that we really try to meet you where you are. That's a phrase that we often use. We understand that you have goals and we have goals, but your goals are the most important, because when you're living with such a serious disease, you're more than your disease, you're more than your illness. And it's so important for you to also have other parts of your life that make you you. And we try to weigh those of what we really do. And that's where the slide rule comes in. You'll see me kind of doing this balancing act, because, when you're getting treatment, such as like we use the example of chemo, there's side effects with that. And where we come is on that opposite end of the scale, to try to like even it out so that you're not quite so down with all the side effects that you could be getting. And you kind of even out the scales. And this analogy can be put in for other treatments for any of the other diseases that Dr. O'Connor brought up. So for an example, we talk a lot about, I use the chemo example, like say a patient is coming in for chemo treatments and they're getting a lot of symptoms and weakness, and they're like, I don't really know what to do because my chemo treatment is impacting my quality of life, but I need the chemo to get the treatment, but do I need that type of chemo? And this is where we really shine, because we kind of straddle two worlds of talking with the physician team and talking with the patients, and we're able to say, okay, you have these two options here, and maybe there's a third, and we really kind of help communicate between the whole teams and the patients and try to figure out, okay, this chemo's not really working. Is there something else we can try? Is there a lower dose? Is there something else we can do? And then throughout all of that, we kind of help you guide on which path you kind of is best for you at that time. Because I think, when you're dealing with so much, there's so many information that's given to you from so many different providers, and we're really there to kind of help you pinpoint, what's going on with treatment, what symptoms am I having, what are my goals, and where do they meet, and trying to really kind of organize it in that way. Um, and that we do with like symptom burden, talking with your other team members, your physicians that are involved in your illness treatment, and also with your family. And another big part of that with your family is preparing for important conversations with your families, because there's so many things that um, we neglect in our world to talk about that are so important, such as like assigning a durable power of attorney and making some of your wishes known to your family. And those are hard conversations to have. Like, nobody wants to have them over dinner. We want to talk about better things. We want to talk about happier days. And I think they're still important though, because they are a gift to give to your family members. And it's important because, no one wants to leave a burden on their family. They want to make their wishes known so that, if their family ever has to make a decision, they know what they want. And we'll talk a little bit about that. I'm kind of getting into Hailey's slides here, which we will lead into next for Hailey Wank.
Yeah, so just like what Dr. Hansen was talking about is our team, helps with a lot of those really difficult conversations that are also just really hard. A starting point for that, which some people may or may not be familiar with, is electing what's called a durable power of attorney. There are durable power of attorneys for healthcare decisions. There's also durable power of attorneys for financial, and our team solely focuses on the ones for healthcare. So with your durable power of attorney, again, you may or may not be as familiar, but it really helps to nominate somebody who, if you do not have capacity, so meaning you do not have the wherewithal to understand the complexity of your medical issues, or say you're, heaven forbid, in a coma or a car accident, you're not awake, your durable power of attorney for healthcare then steps in and acts on your behalf to make medical decisions for you. Another key with, though, electing a durable power of attorney is that you need to talk to them about what those things are that you do and do not want for your health care. It's so difficult to predict every potential scenario that could happen to you. But talking about parts of quality of life that you would find acceptable or not find acceptable is really, really helpful. And again, those are just things that our team, really anyone on our team, can help walk through the parts of that. So we always tell folks, your person doesn't have to be present when you fill out this document. You just need to be able to name who they are and have a phone number and so forth. But we do, again, encourage you to chat with your person about your healthcare wishes. So next slide. So parts of those things that we talk about that are also included in the durable power of attorney, which is, and then the living will or advanced directive part of the durable power of attorney, are some of these, bigger forms of medical interventions and life support that are often big decision points in people's care. So CPR, so that stands for cardiopulmonary resuscitation. If your heart stops, so something on your chest to try to restart your heart, using medications to also restart your heart, and doing those shocks. The use of a ventilator. So if you have a big lung infection or you have a big stroke and you can't breathe, do you want to go on a ventilator? If you want to go on a ventilator, is it something that you want to do, you'd be willing to do for a short period of time, or is it something that you'd be okay, with that being part of your life indefinitely? Artificial nutrition and hydration is also another decision point. If you're unable to eat, physically eat. We see a lot of what's called dysphagia. So that's where the swallowing muscles are no longer strong enough for people to swallow on their own. Or say people have a big cancer in their belly and it's causing an obstruction in their stomach. And so they might need IV nutrition, or they might need a feeding tube that can bypass that obstruction. You know, is that something that you're willing to go through? I think chemotherapy is pretty self-explanatory, but like Dr. Hansen stated, you know, we are the ones that help to really kind of bring together, like, what are your cancer treatment options? What are your quality of life goals? And can those match up? Or are we at the point where, you know, it's something that needs one path or the other needs to be decided on? Dialysis, starting dialysis. Dialysis sometimes is temporary, sometimes it is permanent. More surgeries, IV or antibiotics, and then just overall the quality of life. You know, examples of quality of life that we talk about with folks to kind of get their brains kind of thinking along in the right frame of mind would be, you know, are you a person where you say, you know, if I can't go fishing with my dog actually in my boat, you know, that is not an acceptable quality of life, and I'd rather not live if I can't do that. Or you could be kind of on the whole other end of the spectrum that says, as long as my heart is still beating, even if I can't recognize people or know what's going on, that is still an acceptable quality of life. And so for people, there's a whole spectrum in between there. And so it, you know, it takes some soul searching and lots of conversations to decide, you know, what feels like a good fit. And I also will say too that, you know, where somebody is at on one day with their perspective of their quality of life can change from day to day. You know, me being a younger person, I would say, yes, put me through all of these things. Personally speaking, you know, I don't have really many comorbidities, and I'm a pretty healthy person. But if, you know, say I had stage 4 lung cancer and I had spots of cancer all over my body, and I, you know, more days are bad than good, I probably then would start really rethinking a lot of these, you know, advanced uses of life support and aggressive measures that can be offered to folks. So next slide. So I touched on these, the difficult decisions that our team helps with, preferences on CPR, life support, artificial nutrition, and hydration. I think I talked about those pretty well. Also, a big decision point that comes up for our patients is coming back and forth to the hospital. Is that still providing you benefit? You know, we might not be able to offer more chemotherapy, and not we specifically, but the other members of the medical team. But there might be still some supportive care that can be done, you know, getting like IV fluids, getting IV antibiotics for infections that might be popping up, getting maybe a drain placed in your belly to help relieve pressure from fluid that might build up. So, you know, is coming back and forth to the hospital still helping? If so, that's great. Then keep doing that if that aligns with your goals. But if it doesn't, then we need to discuss, you know, what would be a plan to help you stay at home and keep you comfortable, or wherever home might be for you. So the last bullet point here is along the same lines as you know, a durable power of attorney and a living will. We also have another document that we assist with completing and give to our patients and families. We call it a TPOP. So it's transportable physician orders for patient preferences. And Dr. Hansen, if you don't mind just switching, there we go. So this is a classic bright pink. All over the country, it is this magenta pink. I don't know, I can't remember what the actual color is called, but it's bright pink for a reason. We want this to stand out, whether it is, you know, in your chart at the hospital, whether it's at home in your file cabinet and you can't find it, it's bright pink so that you can easily find it. You know, for our folks who are at nursing homes, it's right there at the front of the chart, because we want people to be able to find these and know instantly what the patient's wishes are. And this document helps communicate that. When I give this to families, I'm like, you know, there's a lot of words and, you know, dialogue here in this piece of paper, but it basically is broken down into 3 sections. You know, do you want CPR or not? How aggressive do you want your medical care to be? Do you want to keep coming back and forth to the hospital? Do you want to keep coming back and forth to the hospital, but you don't necessarily want to go to the ICU if you got that sick? Or do you want to focus solely on your comfort? Box C talks about artificial hydration and nutrition. And then box Z is where it's either signed by the patient, their surrogate decision maker, and then it's signed by a physician. And so these are standing physician orders that no matter what hospital you're at, what clinic, if you're at a nursing facility, if EMS show up at your house and you have this, give this to them so that they can easily see, okay, this person wants X, Y, and Z care going forward. And then it gets passed along, you know, wherever their healthcare goes. So this is a kind of a nice, concise document to communicate those wishes, and then also so that all medical professionals adhere to the patient's wishes. Next screen. So kind of transitioning into a different kind of area, where does palliative care take place? Here at KU, we have the benefit of having multiple locations. I only work here in the hospital. I only see patients in the wards as a consultant source service. So that means that, you know, we provide our input, but we don't take over their whole care. We also have physicians and nurses and our fellows in our clinics. And we have a couple different clinics throughout the city. Our palliative care clinics are all housed in with our cancer clinics, but not all of the cancer clinics that KU has. And that's more specifically for KU, but palliative care can happen in a home setting. It can look like a home health program with like a palliative care spin on it, where the focus is, you know, comfort, quality of life, talking about, you know, what healthcare plan makes sense. It also can happen in long-term care facilities as well. Next slide. So just to kind of summarize, us as the palliative care team, we're here to stand side by side with our patients and their loved ones during their disease process, really at any point, at just like Dr. O'Connor said, at the time of diagnosis, at the time where they're receiving treatment, and at the time when things are not going, you know, as people had hoped. And so just depending upon where people are at, that's where we meet them. And we meet them with all different kinds of needs, physical, spiritual, psychosocial, things like that. And then we also really help to try to advocate for your decisions. We try to help you and your family really decide and isolate what those decisions are, and then we really help for you guys to try to advocate for that for your care moving forward. So, any questions